All right, let's talk about the USMLE. If you're thinking it's all about cramming facts, I want you to hit pause on that idea. Today, we're digging into a totally different strategy, one that's all about the most critical skill you'll need, clinical reasoning. Let's jump in. You know this quote right here? It hits the nail on the head. The USMLE has changed, big time. It's not a trivia contest anymore. It's not about how much you know. It's about what you can do with what you know when the pressure's on. Can you find the exact piece of information you need for the exact patient in front of you? That's the real game.
Okay, so here's how we're going to break this down. First, we'll get past rote memorization. Then we'll lock in those high-yield topics. We'll see clinical reasoning in action, figure out how to choose the next best step, crack the ethics and communication part, and then tie it all together with a solid action plan for you.
All right, first up, we've got to talk about the real challenge of the USMLE. And that means moving beyond just memorizing stuff. Seriously, if you're studying for this like it's another biochem final, you're coming at it all wrong.
And here's why. The whole point of the USMLE is to see if you can act like a doctor on your own with a complex case in front of you. Think about it. Every single question is like a mini patient encounter. The exam is constantly asking, okay, here's the info, what do you do now? It's not about reciting lists, it's about building bridges between ideas.
Okay, so now we're going to talk about mastering those high-yield topics and building your foundation. And look, don't get me wrong. Even though it's not just about memorization, you still need that solid base of knowledge. The trick is to be smart about it and focus on what really matters. So there are a few areas that just keep showing up again and again because they're what you use every day in medicine. We're talking pharmacology, not just what drug, but how it works. Microbiology, not just the name of the bug, but the story it tells in the patient. Immunology, behavioral science, ethics. These are the absolute pillars you're going to build everything else on.
Okay, let's take a super common, high-yield concept, diabetic peripheral neuropathy. It's so easy to just memorize diabetes, neuropathy. But that's not enough. You have to go deeper. You have to know why. It's the high blood sugar damaging the nerves. And not just any nerves, it hits the small, unmyelinated ones first. So what do those fibers do? Right, pain and temperature. That one little detail changes everything. And see, this is where it all clicks together. That basic science fact translates directly into what you see in the clinic. The damage starts far away, in the hands and feet, because those nerves are the longest and most at risk. So when you see that classic stocking glove pattern of numbness and pain in a question, that's not just a buzzword to memorize. It's the actual story of the disease playing out right in front of you. All right, foundation's in place. Now for the fun part, clinical reasoning in action. Let's stop talking theory and actually start thinking like a clinician. We're going to walk through a case and put this stuff to the test.
So picture this. A 65-year-old man, history of high blood pressure, comes in with a sudden, severe, tearing chest pain that's shooting straight to his back. I mean, alarm bells should be ringing like crazy in your head right now. You've got these key words: sudden, tearing, radiating to the back, hypertension. Your brain should be cooking up a differential diagnosis, and a couple of really scary things should pop right to the top. Okay, so the two big bad possibilities here are a heart attack, an MI, and an aortic dissection. And you can bet the USMLE will want you to know the difference. There's often one key finding that helps you tell them apart. So, what is it? What's that one piece of the puzzle that points you in the right direction? This is where the words matter so much. That word tearing, it's not just descriptive flair. It's literal. The inner layer of the aorta is actually tearing apart. That's a dissection. A heart attack, on the other hand, is usually described as crushing or pressure. That's the feeling of a muscle being starved of oxygen. And here's another huge giveaway: a big difference in blood pressure between the two arms. That's a massive clue that the tear is blocking blood flow down one side. It's all about recognizing these patterns. Okay, so you think you've got the diagnosis. Great, but you're only halfway there. Now we have to talk about choosing the next step. This is a huge part of the exam, and frankly, it's where a lot of people stumble.
The key is to have a system, a framework that you use every single time. So what's step one? Always check the vitals. Is this patient stable or about to crash? Because if they're unstable, forget everything else. You have to stabilize them now. If they're stable, then you ask yourself, do I know what's going on? If not, your next step is a diagnostic test. If you do know, then you treat. It's a simple 3-step process, and it works.
Now, when you need to pick a diagnostic test, you'll probably see a whole list of options. So here's a great rule of thumb, kind of an inside tip for the exam. Unless the patient is actively dying and you need the answer 5 seconds ago, the USMLE almost always prefers the test that is the cheapest, the least invasive, and has the least amount of radiation. It's all about safety and efficiency.
And remember, management is all tied up with pharmacology. Let's take a DKA patient. You know you need to give them fluids and insulin, right? But wait, what does insulin do besides lower sugar? Well, here's a little mnemonic to save you: insulin's potassium kiss. Insulin literally pulls potassium inside the cells. If you don't check the patient's potassium levels first, giving insulin could drop them dangerously low and cause a deadly heart rhythm. This is a classic trap on the test.
All right, let's switch gears a bit. We've talked science, but the USMLE is also about the art of medicine. And that means we have to crack the code on ethics and communication. These questions are absolutely going to be on your exam, and guess what? They have their own set of rules. Okay, let's imagine a scenario. It's tough, but it's one you'll face. You have to call a family and tell them their loved one has died. Now, this isn't about guessing what sounds nice. This is about knowing the actual evidence-based protocol for breaking bad news.
So you've introduced yourself on the phone. What comes out of your mouth next is absolutely crucial. You can't just blurt it out, but you also can't dance around it. There is a very specific, most appropriate first thing to say. What do you think it is?
And the answer is, you gently ask, what do you know so far about your family member's condition? It might sound simple, but it's brilliant. This comes right from the SPIKES protocol for these situations. It does 2 incredibly important things. First, it tells you what they already understand. And second, it creates a bridge, a starting point for you to fill in the gaps. It's the most compassionate and effective way to begin.
Okay, we have covered a ton of ground, from mindset and high-yield facts to clinical reasoning and communication. Now, let's wrap this all up into your strategic action plan, something you can start using today.
So here's what I want you to take away from all this. First, always use the 2-step. What's the diagnosis? Then, what's the next best step? Second, prioritize threats. Always be asking yourself, what's the most immediate danger here? Third, go deep on the fundamentals. Understand the why behind the high-yield facts. And maybe most important of all, analyze your mistakes. When you get one wrong, your job isn't to learn the right answer. It's to figure out why you picked the wrong one. That's how you really grow.
Look, at the end of the day, this isn't really just about a test. It's a stepping stone, for sure. But the skills you're building right now, how to think critically, how to prioritize, how to communicate, these aren't just for the exam. These are the skills that make a great doctor. So my final question to you is this. You're preparing for your whole career, not just one test. What's your next best step?